Good evening, everyone. I am Matthew Carreau. I'm a gastroenterologist here for the last 21 years with Gastroenterology of the Rockies, and we've been associated with Boulder Community Health during that whole time. I'll be talking today on trying to prevent colon cancer, which is very close to my heart. It's what I've been doing for most of my professional life. Why are we talking about in March? Well, March is Colorectal Cancer Awareness Month. The governor, Jared Polis, signed this into effect back in 2019, and the color we get to use is blue, which works well for me. It's one of my favorite colors. It's the color of our scrubs. And these three people seem to be very against colon cancer because they're all in blue. I don't know them personally, although I have seen them on stage. So let's get to the talk. So colon cancer, it's clearly a preventable killer. It is a result of a sequence of biological events that we call the adenoma-carcinoma sequence. Colon cancer is common, it is lethal, and it is preventable. So what is colorectal cancer? It is cancer of the large intestine. This is a picture of the large intestine with the different sections located. I get frequent questions when people come in for screening colonoscopies and ask why we do not look at the small intestine. The small intestine is the most rare cancer in the GI tract. Colon cancer is the number 2, or used to be, I should say, the number 2 cancer killer nationwide. That's why we pay attention to it. What does it look like endoscopically? It can look like this type of mass with an indentation. Polyps will be smaller. They can start to grow larger and very large. That's what we will see during colonoscopies. So I mentioned the adenoma-carcinoma sequence. When I was studying this back in the 80s and 90s, this was the only known normal cell to cancer cell gene sequence, and I believe that is true to date. They could tell you exactly what happened in the colon DNA, the colon cell DNA, going from a normal colon cell to slightly abnormal, to a small polyp, to a large polyp, and to a colon carcinoma. I can't remember all of the steps, but currently I only remember the p53 suppressor gene and oncogene. But they can tell exactly what goes on. How long does this take? It takes quite a long time. We estimate it takes 10 to 15 years to grow from an abnormal cell into a colon cancer. And that is why colonoscopies can be scheduled at 10-year intervals. How common is colorectal cancer? It's extremely common. It accounts for at least 8 to 10% of all of the cancers diagnosed in the United States. It is also similar in Colorado, slightly less percentage, but still significant. So let's talk about what we've done over the last 20, 40, 50 years in colon cancer screening and prevention. What's the good news? The good news is we have made significant strides in preventing colon cancer and colon cancer deaths in patients age 50 and over. A significant decrease occurred around 2000 when colonoscopies became much more common for colon cancer screening. What's the bad news? Well, the bad news is it seems to be increasing in patients that are younger than age 50. Specifically in patients age 45 to 50. They seem to have a similar risk currently as patients age 50 to 55. What are the different risk factors for developing colon cancer? Well, some of them you can't modify at all. You can't modify where you came from. The older we get, the more likely we are to develop cancer. Men are slightly more likely to develop colon cancer than women. Patients of African descent are higher risk to develop colon cancer and at younger age. There is also a clear association with socioeconomic status. If you're in a lower socioeconomic status, you have higher risk for colon cancer. And there's probably multiple different reasons for that, including lifestyles. Family history. Family history is by far the most important indicator of colorectal cancer risks. So let's look at that for a bit. We're only going to talk about first-degree relatives. There's lots of data on second-degree relatives, but I'm not going to get into that tonight. So first-degree relatives are parents, siblings, and children. If you have one first-degree relative who had a colon cancer at any age, your risk is about 2.5 times increased over the general population. If that relative that first relative, I should say, with under the age of 50 is significantly increased, up to 4 times. If you have multiple relatives, 2, it's increased, and more than 2, significantly increased. That's why family history is one of the things that we ask all the time. Patients who have hereditary abnormalities such as Lynch syndrome also have a significantly increased risk of colon cancer. So what do? How do we try to prevent those in those patients? Well, our screening intensity increases as your risk increases. So what are some of the risk factors? We talked about the ones that you really can't change, your demographics. What about lifestyle? Well, a healthy lifestyle is healthy. That hasn't changed in decades. If you smoke, that's going to increase cancer risks of all type. If you're overweight, if you don't exercise, if you drink alcohol, those will all increase your risks as well. When I started practicing GI, we all thought that diet played a role, but we had no good evidence. It's a very difficult study to make to control people's diets over 5, 10, 15 years to get that data, but they did think they have it, and it confirmed what we always thought. A healthy diet is healthy. Patients who eat more fiber, vegetables, avoid red meats, avoid processed meats, they will have lower risks. Patients who don't eat healthy will have higher risks. And that goes for most cancers, as well as heart disease and hypertension and everything. We're in Boulder County, most of us, I think, are listening to me tonight. So most of us will probably live somewhat of a healthy lifestyle, but it clearly benefits you. Okay, what's the biggest risk factor? By far and away, the biggest risk factor for developing and dying from colon cancer is failing to get screened. Right? Screening is essential in detecting early cancer or preventing cancer from developing. So I think that's really what most people want to hear about tonight. What are the different screening methods? We'll get to that in a minute. So how deadly is colon cancer? Well, when I started practicing GI, it was the second leading cancer death in the United States. Currently, it's dropping, and we hope that it will continue to drop with early detection and prevention. Colorado mimics the United States. It's about, I think it's 8%, 1/12 of the deaths in Colorado from cancer are related to colon cancer. Colon cancer. So we stage colon cancer, and that's what we talk about early detection. So colon cancer staging. I'm going to try to use my little cursor here if you can see it. Stage 1 colon cancer is the earliest stage. Stage 1 is contained within the colon, either within the polyp itself or within the colon. It's not spreading into the layers or having spread distally. Stage 2 extends into the layers of the colon wall, may grow through the colon, may abut other tissues, but has not really spread significantly. Stage 3, unfortunately, is already in lymph nodes, and stage 4 is metastatic, meaning that there are cancer cells in the liver or the lung or elsewhere in the body. How does this affect survival? Tremendously. You can see stage 1 survival, 80 to 90% of people survive 5 years from that diagnosis. If you have stage 4, the 5-year survival rate is dismal. It's less than 5%. Now, an interesting thing between stage 2 and stage 3, just a slight aside from the oncologists that I speak to, if there is 1 or 2 lymph nodes that are positive out of 18, they respond more like a stage 2. And if there's 10 or 12 out of 18 or 20, they respond more like a stage 3. Those patients will need chemotherapy, I should say. So detecting cancers early is critical. If we don't detect them early, they're lethal. If we detect them early or we can prevent them, then it's not as big an issue. So this is about the most important stuff that I think. It is about the early detection and the type of screening. So what can you modify? You can modify your lifestyle. Right? We all know this to be true, right? If your weight is stable throughout your life and a good BMI, you have less diseases of all types: heart disease, hypertension, colorectal cancer, everything. If you're physically active, we recommend about 30 minutes each day of physical activity. That also decreases risk of colon cancer and most diseases. And your diet. Diet is important. If you eat a lot of red meats, you don't eat a lot of fruits and vegetables, you're going to have a higher risk of developing colon cancer. The processed meats seem to be worse, and meats cooked at high temperatures may also have an effect. Smoking is huge. Patients who smoke have higher risk of every single type of cancer. In addition, it harms your lungs, it harms your heart, it's just terrible. Alcohol, even mild to moderate alcohol intake, seems to increase risk of colon cancer. Aspirin. So this is what we call chemoprevention. Is there something that you can take that decreases polyp formation and colon cancer development? Yes, but with a caveat. Aspirin has a high side effect profile. So we talk about risk-benefit ratio in medicine. If the risk is too high and the benefit's too low, we may not want to use it. Aspirin causes a lot of GI bleeds and ulcerations and CNS, central nervous system bleeds, a lot of other stuff. So its risk-benefit ratio is not positive for average risk individuals. Where is it useful? In selected groups who have significant genetic abnormalities. So. Screening. Screening is by far and away the biggest risk factor, or I should say lack of screening is the biggest risk factor for developing colon cancer. So, screening. We're talking about early detection and prevention. They're two different things. Early detection detects cancers at an early stage. Prevention removes the precancerous growths and prevents the cancer from developing. Early detection are your stool tests. Prevention is imaging the colon, recognizing polyps, and then having a colonoscopy to remove those polyps so they cannot grow into a colon cancer. Okay, stool tests. The stool tests are not good to pick up small polyps or moderate polyps. They're okay to pick up large polyps, and they're okay for cancers. But they miss a lot of stuff, and they also have a number of false positives. So currently, there are 3 different stool tests that are on the market. There's the Hemoccult test that has been around for decades. That just measures hemoglobin, not specifically human hemoglobin, but any hemoglobin. Hemoglobin is the oxygen-carrying molecule in blood. The FIT test is much more specific for human hemoglobin. The Cologuard test, which is much newer, combines the FIT test with a DNA test that looks for some of those abnormalities that we associate with polyps and cancers as they grow larger, KRAS and such. The Cologuard test measures both the blood or the DNA. It doesn't tell you which one is positive. The FIT test only measures the blood. They're pretty equal if you look at the studies. The Cologuard test does not seem to add a whole lot to the FIT at the present time. My expectation is that the Cologuard test in 10, 15, 20 years will be much better and will be detect polyps earlier. But currently, it is an early colon cancer detection. It is not a prevention. One little aside here. One of the things that many people don't understand about colon cancer screening is some of the cost, which is one of the bad portions of our US healthcare system. Any of these are considered screening tests. If you have a positive FIT test, Hemoccult, or Cologuard test, you then are sent for a colonoscopy. That colonoscopy is now not considered a screening colonoscopy, it is a diagnostic colonoscopy. And what that means, it is not covered under your screening benefits, and it goes to your copay and your deductible. Many people don't understand this, and they come in with a positive test, and they are not happy with the cost because they thought it would be screening. These are screening tests. If it's positive, the colonoscopy is evaluating a positive test, and the insurance companies will look at it differently. I don't like that, as you can probably tell. Okay, so let's talk about the prevention. That's the imaging and removing the polyps. Right? The imaging involves 2 different tests. Those are endoscopic tests and a virtual colonography, which is a CT scan. The different endoscopic tests are either the flexible sigmoidoscopy, which is shown, let me see, is that the right of the screen when they're looking at it? Okay, let me use my cursor. The colonoscopy, the flexible sigmoidoscopy is shown in A here, and is designed only to look at the left portion of the colon. It does not extend all the way through the colon to the cecum. The colonoscopy evaluates the entire colon all the way around. We can then find polyps, and here is a picture of a small little snare that we will open up, put that around the polyp, and then cut that polyp up and remove it from the body. Flexible sigmoidoscopy, it's in all of the screening guidelines, but it's not really an adequate test in my opinion. I will give you the analogy that it's like getting a mammogram on your left breast only. I mean, it's better than nothing, but if you're going to have us do an endoscopy, I would certainly recommend a full colonoscopy and not the flexible sigmoidoscopy. For colon cancer screening, that is. Okay. So what about CT, virtual colonoscopy, or CT colonography? It is certainly part of the guidelines, and it has a role in the screening and detection. It is a CAT scan. It has radiation. You do have to take a similar type of prep to clean your colon out. I do not believe you're given sedation. You're awake during that, and they put air in. If they find an abnormality, you are then referred over for colonoscopy, and again, that would not be considered screening. The CT colonography, one of the benefits of it, is it does see everything outside of the colon. When I have a colonoscope, I only see the inside. The CT scan will look at all the other organs, and they may pick up incidental findings that may be important. Okay. So when we talk about screening, we separate patients into average risk groups and high risk groups. The average risk groups have no family history and no personal history of any colonic neoplasms, which is adenomatous polyps or cancers. Inflammatory bowel disease has a different risk of cancer, which does not form in polyps, and these patients will also need a more intense surveillance. So when do we start colorectal screening? Well, there's a little change here. Historically, it has always been age 50. However, as I showed you on some of the slides previously, the younger age group, specifically 45 to 50, are now having an increased incidence of polyps and colorectal cancer. The American Cancer Society has dropped their age, and I'm going to be talking about that in some subsequent slides. I do believe that the United States task force that discusses and decides on colon cancer screening will also drop their age to 45 very soon. Okay, so here are the options for screening. We talked about the stool test. The Hemocult test and the FIT test are stool tests. They're easy to do. They're inexpensive. They need to be done every year. But again, if they're positive, you are then sent for a colonoscopy, which is diagnostic. The Cologuard test, FIT DNA test, is currently recommended every 3 years. It has a much higher cost. It's a couple $100. It may come down in time, and I do expect it to be much better 10, 20, 30 years down the road. Okay, flexible sigmoidoscopy is recommended at 5-year intervals, but again, I don't recommend flexible sigmoidoscopy for colon cancer screening. It is in all of the guidelines. It just does not seem as appropriate as a full colonoscopy. The CT colonography is recommended every 5 years. The reason for that is it has somewhat less sensitivity than colonoscopy. They will miss flat lesions more than colonoscopy because they're not raised and they don't show up well on the CT scan. Colonoscopy, which is still the gold standard for both detection and prevention and removal of polyps, is recommended at 10-year intervals. And everyone questions that, but if you remember from the adenoma carcinoma slide, this, we think, takes 10 to 15 years to develop a cancer from an abnormal cell. So although it is expensive, it's annoying, I know you have to take the laxative, it's not palatable, it does not need to be done for 10 years, and therefore, its cost effectiveness is very reasonable. Okay. If any of these are done, any of them, this will decrease colorectal cancer deaths in cases by an estimated 60 to 80%. That's huge, any of these. So I always tell everybody, please do some type of screening. It doesn't matter what. I believe colonoscopy is the best, but if you do something, we will be able to decrease your risk of developing and dying from colon cancer. It's very important. Okay. All right. So here are the current guidelines, which are slightly different from the United States Task Force and from the American Cancer Society. So the task force still recommends to start screening at age 50. It continues till age 75. We individualize colonoscopies between 75 and 85, and almost all of our guidelines say after 85, you rarely, if ever, do a screening colonoscopy. Okay, so one of the questions I always get to at the time when I do screening colonoscopies is, when do I stop? Well, if you're 85, I think you stop. I also will tell patients that computer models suggest if you're living 7 years, we will benefit you by taking a look at ages 85 and under. Now, if you're 83 or 84 and it's a 10-year interval, questionable. If you've had large polyps in your surveillance program, that'll be something different. And I think we'll have some questions on that later. Okay, so colon cancer is increasing in younger ages, as I said, specifically age 45 to 50. The American Cancer Society a couple years ago did a lot of very good studies, and they recognized this, and they recommended that they start at age 45. If they start at age 45, their model suggests there'll be somewhere between a 4 and 8% decrease in the number of cases and an 8 to 11% decrease in the deaths. Why? Because those young patients will present later and they'll have later stage disease. So we're preventing the cancers, but we'll prevent more deaths. Unfortunately, we'll need more colonoscopies in that group, which adds cost to the U.S. healthcare system. But I do think, as I've said before, that colonoscopy is one of the few cancer screening methods that has been shown to be cost-effective and save lives. Okay, so currently we have one group recommending age 50 and one group recommend age 45. Are you covered at age 45 in Colorado? Depends on your insurance. So the states will determine which guidelines they follow. Currently, Colorado is following the U.S. Prevention Task Force guidelines and not the American Cancer Society guidelines. So most insurances in Colorado may not cover a colon cancer screening at age 40, under age 50 for an average risk patient. I do know that I believe Aetna, which is the insurance for American Cancer Society, will cover it no matter what state you're in. But you'd have to check with your insurances. I do believe that all of this will soon change to age 45 with all of the different recommendations. But currently we're in this little bit of a limbo. Okay. Who's at higher risk? Well, we talked about family history. Anyone who has a first relative with colon cancer is at higher risk, and they have to start younger. How young? Well, it will depend on the age of the individual who had the colon cancer. So currently, if that individual is under age 50, you would start 10 years younger than they were. Otherwise, you start at age 40. How often will also depend on how many relatives have the colon cancer and at what ages. But you do start earlier if there's any family history. The genetic syndromes, there are a number of genetic syndromes, and I'm only going to mention two. Hereditary syndromes of HNPCC, which is hereditary non-polyposis colon carcinoma, or Lynch syndrome, and FAP, which is familial adenosis polyposis. These patients will develop polyps and cancers at much younger ages, and their screening starts very young. With FAP, age 13, they will start with screening, and with HNPC or Lynch syndrome, it's about age 25. Okay, here's a little diagram of showing why we need to start earlier. If you look at these two curves, you can see that patients with family history, 10 years younger, they have the same amount of colon cancer as patients with no family history. So that's why we start younger with family history. Okay. People are always concerned if they have a family history, but the vast majority of people who are newly diagnosed with colon cancer have no family history. Why? Because they're the largest group of people. The people with family history are much smaller. So family history certainly increases it. The HNPC counts about 3% of colon cancers, but sporadic or people with no family history, about 70% of the colon cancers. So even if you have no family history, it's still important to get screened. Okay. All right. Lynch syndrome, that's one of the more common genetic syndromes. It runs in families. It's autosomal dominant. Cancer risk is extremely high. The cancer starts at early ages, and it tends to be in the right colon or proximal location, requiring a colonoscopy to find the polyps and not a flexible sigmoidoscopy. There are other cancers associated with this, so when patients come in to see me, I ask them not only about colon cancer, but I ask them about any other cancer in the family. The common cancers in Lynch syndrome are ovarian cancer, uterine cancer, but you can also have thyroid cancer, gastric cancer, pancreatic cancer, breast cancer. There's lots and lots of them. FAP. Okay, I'll just skip that. FAP, these patients form hundreds of polyps in their colon. It is a striking picture. This is a picture of all the polyps that this one patient has. They are guaranteed to develop colon cancer during their lifetime, usually at younger ages. If they start to develop these polyps, the recommendation is to remove the entire colon. We cannot keep up with this polyp burden. We will not be able to remove them. We'll have complications. Patients will develop cancer. I think I hit that. So these patients will have genetic testing, and if they carry the genes, they get screened at age 12. And once they start to develop these polyps, their colon is removed. Now, there's an attenuant with FAP. It's different. Patients will form a lot of polyps. They're usually on 3-year intervals or less because of the polyps they form, but we believe that we can keep up with their polyp burden and prevent them from developing a cancer. Those are quite striking things. Okay. So just a summary here. Colorectal cancer is truly preventable. It has a clear progression from a normal cell to a polyp to a cancer. It is common. It's common in the United States. It's common in Colorado. We are making a dent in the colorectal cancer above age 50, but we're not doing it well age 45 to 50. As I said, when I first started practicing GI, it was the second most common cancer death in the US. It's dropping. I think it's third now. I'm hoping it'll be fourth and fifth and continue to drop. What can we do? Well, prudent lifestyle changes, certainly. Don't smoke, drink moderately or none at all, be physically active, eat a healthy diet, don't eat too much red meat or processed meats, and please get screening of any type. The patients who have hereditary conditions, they're somewhat different, and we'll treat with them somewhat differently, and they'll see genetic people. But please, I have to stress again that any type of screening is going to decrease colon cancer incidence and colon cancer death. So please, please get screened. That's all I wanted to say, and I want to really open up for a lot of questions. I'm sure you have a lot of questions. I do have to say it's slightly strange giving a lecture in an auditorium with 3 other people and a camera. So I hope it goes well over the internet.
That was a great presentation, actually. Yes, it has come over quite well. And we are going to start getting a bunch of questions coming in, but I've captured a couple, and
Okay.
I'd like to, yeah, it was a really great presentation. Appreciate that. All right, the first question is, I have colonoscopies every 3 years because I usually have non-cancerous polyps to be removed and biopsied. Yeah. Is a 3-year cycle still recommended for someone like me at 75 years of age?
The caveat there would be life expectancy. If you're a healthy 75 and you're expecting to live 5-7 years, especially with your history of having polyps form pretty quickly, absolutely yes. A 3-year interval is indicated if you have any polyp, precancerous polyp over 1 centimeter, 3 polyps of cancer potential of any type, or more aggressive pathology such as villus pathology. Those all increase your risk, and as long as you're expecting to live 5 or 7 years, I would certainly recommend you going back in at the prescribed interval.
Thank you. Here, I'm going to just do this real fast. All right. Next question. Does curcumin help with prevention?
No data to support or refute that. So that is a non-committal, don't know.
How do you know if you should get the genetic testing?
The genetic testing is based on family history. So if you have a significant amount of family members with different cancers, especially if they're occurring at young ages, you should be having a genetic counseling and possibly genetic testing.
Can a colonoscopy be done without anesthesia?
Absolutely. Colonoscopies are uncomfortable. They can be quite painful in some patients. In some patients, they can be very easy. I will not know until I do a colonoscopy how easy or hard it will be, but there are some times that I can get through the entire colon in about 60 seconds with very little pressure, and I think those patients will do fine without sedation. I have other patients who are in significant discomfort and sometimes really need more of an anesthesiologist to sedate them. But it certainly can be done without sedation, but it can be uncomfortable or painful.
Absolutely.
And we do it all the time. I talk my patients through it. I kind of know the colon has one sense. That sense is stretch. All right? So as I'm moving around the colon with my tube, I'm going around curves, so I'm making these big loops as I go around. I know when I'm doing that, so I can talk to the patient and tell them, you're going to feel this, how is it, what's going on? But some patients do, usually, some patients abort it and say, no, I have to have sedation, and other patients fly right through it. But we certainly can do it without sedation.
I'm going to try to pronounce this properly, is diverticulitis in the large or small intestine?
Diverticulosis can occur in either of the intestines. Diverticulosis is a weak spot in the wall of the colon that pooches out over time. It's really a weak spot where a blood vessel on the outside puts little feeder vessels to the inside. So there's a small hole where that goes through, and as your colon has contractions over 50, 60 years, they start to pooch out. In America, we find diverticulosis at age 50, 5 to 10%, and at age 65, more like 2/3 of us. Diverticulitis is the infection in that outpocketing, but diverticulosis is just the presence of them. Diverticulosis, as I said, could be in small or large intestine, more commonly in the large intestine. It has no association with colorectal cancer at all.
Are rectal and anal cancer screening included as part of a colonoscopy?
Well, rectal cancer is included in the colorectal screening, and the anal cancers, when we do the colonoscopy, we do a visual exam and a digital exam, and if we pick it up there, yes, we can pick it up. So anal cancers can be picked up, rectal cancers is part of the colon cancer screening.
I've heard of some people suffering a tear in the colon during a colonoscopy.
Yes.
What's the possibility that this may happen and what is done?
Okay. So nationwide averages for perforations in the colonoscopy, we quote 1 in 1,000 is what the nationwide averages are. Colonoscopy is clearly operator dependent, right? And finding polyps and removing polyps is a skill that you learn and perfect over time. We all have had perforations. I think I've had 4 perforations. I've been doing this 27 years, 50, 60,000 procedures. So I still quote 1 in 1,000, but I think it's a lot less than that. It does happen. It is a significant complication.
Are all polyps worrisome?
No. Certain polyps have no cancer potential. There are a type of polyps that are inflammatory that have no cancer potential. Tiny little distal hyperplastic polyps have no cancer potential. Adenomatous polyps are the polyps that can turn into adenocarcinoma. So not all, we remove polyps, and a lot of times the recommendations are if it's this type, it's normal and we can do it in 10 years. If it's this type, it could be 7 years or 5 years. So all polyps are somewhat different, and some have no cancer potential.
How does a normal cell develop into an adenoma or a polyp?
Well, if I really knew that, I would be one of the big biochem people or a supernatural being. They do know that it does change, and we do know some of the risk factors. The exact why it does, I don't have the knowledge to answer that. But we do know the adenocarcinoma sequence, and we also know that polyps turn into cancers. Historically, if patients had barium enemas, but they never had a colonoscopy to remove it, they would find a cancer in the spot that the polyp was. Did I answer that question appropriately?
Yeah.
Think so? Okay.
I think they'll let us know
Okay.
if they'd like you to answer more. Is a constant loose stool any bad indication of an unhealthy large intestine or increase the risk of polyps?
No, the diarrhea loose stools do not increase risk of polyps, but the question is, what's the etiology of the diarrhea? Is it related to an ulcerative colitis? Is it an irritable bowel syndrome? Is it a microscopic colitis? Is it celiac disease? What's it related to? So patients who have diarrhea may need colonoscopies for evaluation of their diarrhea, but the diarrhea in itself is not a risk factor to develop polyps or cancer.
Is inflammatory bowel disease just as dangerous as colon cancer?
So inflammatory bowel disease is a terrible disease in itself, and it can have significant effects on people's health, especially Crohn's. Both Crohn's colitis and ulcerative colitis have an increased risk of colon cancer related to the ongoing inflammation. So patients with ulcerative colitis and Crohn's colitis will form cancer or may form cancer in a different way than I will. I'll form polyps, and then the polyps will grow and they'll grow into a cancer. They have this increased destruction and repair of their intestines, and the DNA repair mechanisms can't really keep up with all the cells that they're destroying and repairing, so DNA mistakes get propagated. Most kill the cells, but some don't, and those cells can grow abnormally. With patients who have long-standing ulcerative colitis or Crohn's colitis, we have to do surveillance colonoscopies and random biopsies looking for this dysplasia, which we may not see, but if we find in a biopsy, that has a cancer risk. So Crohn's and ulcerative colitis have their own risk factors. They can be terrible, but they certainly increase colorectal cancer. But I'm not sure I could say one's worse than another. I mean, you have an early colorectal cancer that's cured and terrible Crohn's disease that's terrible for your life. They could both be bad, but they're different. So I'm not sure I can answer which is better. Oh, is it not up? Yeah, it's up here. I don't know. Reed, did it go up, go off there? It doesn't matter. So,
yeah, there is a copy of the slide presentation available for people to download if they can't see the screen right now, or the right side of the screen. When does the colon get too thin and dangerous to do a colonoscopy?
I think that question is asking about age. And so people ask me, as you get older, is it riskier to do colonoscopies? Yeah, maybe, but there isn't, we don't have an age to say the colon can't take this. Now, if you have an active infection like a diverticulitis, we don't want to scope you with an active infection. We want to wait till that's treated and healed 6 to 8 weeks. If we're doing a colonoscopy in someone with horrendous colitis, we may stop for fear of causing a perforation. But there's no measure of colon strength. And so I don't think that, I can't really answer that. But it would really be more age and life expectancy, not the strength of the colon wall.
If you have UC, how often do you need to get a colonoscopy?
Okay. So, ulcerative colitis, the cancer risk in both ulcerative colitis and Crohn's colitis is very clearly associated with the degree of inflammation, the severity of inflammation, and the length of inflammation. The current guidelines are recommending that we start some type of colon cancer screening after patients have had the disease diagnosed for 8 to 10 years. Eventually, patients who have ulcerative colitis for many years may end up on annual colonoscopies. They're between 1 and 3 years, and they're individualized per patient.
I had my last colonoscopy 2 years ago at age 70. Do you recommend another in 2028 when I'm 80? I've never had polyps.
And then if the caveat is also no family history, the answer would be how healthy you are at age 80. If you have a very big life expectancy, you can have another colonoscopy. But yes, somewhere between 75 and 85, we stop based on life expectancy and patient's preference. So my family, if you were my mom, who's now 91, at age 80, she had a colonoscopy.
Okay. I've had colonoscopies every 5 years since age 40 because my father had colon cancer. I'm now 69. Should I go every 3 years instead of every 5 years?
No, the interval does not change based on family history with age. It would only be based on what they find at that time. So if they find 0, 1, or 2 polyps that are smaller than 1 centimeter that have no villus pathology, 5-year interval is appropriate.
If folks are concerned about this, there's another question related to a perforation. Do you know during the procedure if there's a perforation?
Oh, yes.
Or
yes.
is this discovered post-op? And
Well, so
then
if a perforation occurs during the procedure, it is obvious. I mean, it is the patients are in pain, their vitals change, is an obvious thing. Plus, you recognize that you lose pressure and you're looking at something that's not the colon anymore. So it's quite obvious. People can have delayed perforations from when we use electricity to remove polyps. The electricity can damage the tissue. And there are some patients who can go home and feel well and then later that night have a perforation. It is really is a catastrophe. Everyone recognizes it right away. It is painful, it's not subtle.
Do you have an increased risk for colon cancer if you have a tortuous colon?
No. That's a description that we use to describe a colon is quite twisty and very difficult to get around, but it does not increase your cancer risk. Those are the patients who will probably need sedation. Those are very difficult and uncomfortable colonoscopies.
Alrighty. Does the presence of small and large mouth diverticulusum in the, oh good gracious, in the sigmoidal colon present an increased risk of colorectal cancer?
No. So again, diverticulosis is completely separate, different beast, has nothing to do with colon cancer. And by the way, at diverticulosis, we are trying to re-educate everybody. So when I started practicing, we used to tell people not to eat seeds, nuts, or popcorn with a theory they got stuck in there and caused an infection. That's not true. All the studies with high fiber show that people get less infections. So we're now re-educating everyone that please eat all your fruits and vegetables. You do not need to avoid seeds or nuts if you have diverticulosis or diverticulitis.
Okay. So when it's time, when you're reaching age 50, and how do I get in to see you? Does my primary doctor recommend?
Yeah. So we have open referrals. So the primary docs refer patients for screening colonoscopies or surveillance colonoscopies all the time. We don't need to see those patients in the office. If they're unhealthy, we may, and there's a whole intake that we do to take their history and see, but we do a lot of direct access colonoscopies. So you can call the number and get a colonoscopy. If you need a referral from your doc, then get a referral from your doc.
All right. Is there any chance that insurance will start covering diagnostic colonoscopy?
No, because they're insurance. Yeah, so no, the insurance companies, they will fight to keep every penny and not pay us or have you pay. If they pay out, it's a loss. So they'll do everything not to pay. They will never pay for diagnostic colonoscopies, in my opinion. What I want them to do, just another aside, this is one of my things, my little pet peeves about surveillance and screening. Surveillance may be covered by certain insurances and not. Surveillance is when you come back in and you've had a polyp and we look again. And some insurances won't cover it. That'll be diagnostic, which we are trying to change in the Congress and the Senate. They are putting an incentive barrier to the people at risk the most to get a colonoscopy. It's just terrible. Now, the example I use to describe how silly this is my family. My family is on a 5-year interval because my dad had really nasty polyps. So I have a couple brothers. Some have had polyps, some hasn't. The one who lives here in Netherlands, he didn't have polyps, but let's say he did. So he and I go to my practice and see my partner on the same day every 5 years. He had polyps, I never have. His is surveillance, mine is screening. What's the difference? We're coming in at 5-year intervals for a procedure, and the insurance company will say they don't cover it. So we're trying to get that changed. Please write your senators and congressmen. The only way to get it changed is have them enact new laws.
Here is a question. We've had a couple of people ask about this. Is the scope disposable, or if it is reusable, is there a chance it won't be 100% sterile?
Oh my, they are treated with such high temperatures and different chemicals, and they're tracked through and through, and we have no incidents of ever having any transmitted infections from our colonoscopies. When you see reports of that, like the VA, I think in Florida, they don't clean them correctly. They always have mistakes in cleaning. We haven't, and we are proud of that. We track all the scopes through all the cleaning processes all the time.
Is there a pill or a camera you can swallow? When might it be recommended?
No, unfortunately not. So the pill camera for the colon cancer screening really does not get good pictures. The colon has these folds and it sticks behind it and it just is inadequate. The pill camera that we do use, we look at the small bowel more for iron deficiency anemias, but it does not do well with the colon.
Pathology revealed for this guest, pathology revealed, here we go, adenomatoous tissue?
Yeah. That's an adenoma.
Adenoma tissue. So, recommendation was another colonoscopy in 6 months. Should I be concerned? Is this unusual?
So, if they have an interval less than a year, that is related to what we call a piecemeal polypectomy, a big polyp that you can't get in one bite, and you have to take bites and bites of it. What they call interval cancers, cancers that occur within a couple years of a colonoscopy, they had occurred in two major scenarios. One was not a good prep in the right colon, and the other was when we took out these polyps in pieces and we asked people to come back in 3 years. And a lot of times we come back and there would be a cancer there. So if we do a piecemeal polypectomy of a large adenoma, and they're usually sessile, which means flat, that's 6 months to 1 year follow-up. And that's very important. You may have residual tissue that can grow into a cancer from that spot. So that's my assumption. I haven't seen your report, but anytime we do a 6 month to a year follow-up, that's a piecemeal polypectomy.
If you've had hemorrhoids removed, is there a concern for polyps?
No.
Okay. What do you consider to be the easiest prep?
That's very individualized. Okay? So the big gallon preps are extremely difficult to take. I've done 4 colonoscopies over the last, 20 years. I've drank the gallon prep. I've drank some over-the-counter Miralax Gatorade prep, which is smaller volume, and I've done a SU prep. The smaller volume preps are easier to take because you don't have to drink as much. They may taste terrible. They need to be flushed with a lot of water because they can hurt the kidney, so you really need to flush it out. We also are doing what we call split preps. The right colon, the polyps in the right colon tend to be flat, and the polyps in the left colon tend to be pedunculated or on a stalk. Why is that? Well, stool is liquid in the right colon, and so it has no friction as it's moving over this abnormal tissue. Stool gets solid as it moves through the colon, and then as it moves over the other polyps in the left colon, it pulls them up, so they stick up. So if you had a poor prep in your right colon and it was coated with stuff, but it wasn't full of stool, but we couldn't see that flat lesion, you developed a cancer. So the two things, if you do a piecemeal polypectomy, you come back in 6 months to a year, and if it's not a good prep, it doesn't count, and you can come back tomorrow. So in order to get a good prep in the right colon, we do a split prep. You drink one of the laxatives hours and hours before, a lot of times the evening before, and the second dose of the laxative is taken between 5 and 3 hours of the procedure to clean everything down that comes down overnight. We call it chyme, C-H-Y-M-E, but it's bile, it's mucus, it's enzymes, and it can really coat it and prevent us from seeing very well at all. And so that's why the split prep also makes it more tolerable because you're not taking it all at one time. Now, if you have kidney disease, we cannot use a lot of the small volume preps because we're worried about your kidneys, and then you'll have to drink that whole gallon of junk. So they have gotten easier. They are not, I'm not going to call them good or tasty in any way, but they've gotten a lot more tolerable. I can tell you, I personally do it. Right?
What is that prep liquid made of?
Different
what
ones are made of different stuff. So the gallon prep is a polyethylene glycol. It's ethylene glycol, but all these molecules stuck together, so it doesn't get absorbed. it's an osmotic laxative. It brings fluid in and it makes you have diarrhea related to that. But it's tough. That's the toughest of the stuff to drink, in my opinion.
What information do you provide the patient after a colonoscopy?
They have the complete report, the same report that we keep, and send back to their primary doc. They go home with a report that has pictures on it. If we removed any tissue and we have to call them with the pathology, we always call them, and if they want a copy of that, we get them a copy of that as well.
Oop, lost it. Oh no. How do you test for iron deficiency anemia?
The iron deficiency anemia is tested on a blood test, a complete blood count in the iron studies. If you have an iron deficiency anemia, by far and away the most common reason for that is blood loss. If you don't recognize blood loss, the most common reason for that is somewhere in your intestines. If you have an iron deficiency anemia, the recommendations are to do both an upper endoscopy and a colonoscopy for evaluation for the blood loss. And we actually find more stuff on the upper, more esophagitis and gastritis than we do in the colon.
Is it common to have a sensitive stomach for a week afterwards?
Not so common, but it certainly can happen.
Does colon cancer stage 3 at 81 affect memory? My parents' memory has gotten worse in the last year.
No, but if they're getting chemotherapy, I don't know if the chemotherapy is affecting any of that. But the stage 3 should not be affecting that. But everybody's body is a little different, and everything's in equilibrium. And when one thing's upset, can other things go haywire? Yes, but it's certainly not a common complaint or side effect that we see from that.
Are you saying that if I had a colonoscopy and a polyp was found, every subsequent colonoscopy starting in 7 years would be considered diagnostic?
Not clear, so that depends on your insurance. And each insurance company may have 150 different policies, and it may be covered on 100 of them and not on 50 of them. But that is something that we can clearly have our government change. They just have to change the law. I mean, it's clear, it's very obvious that they need to do that. We just have to keep writing them letters and get them to do that.
Alrighty. I've done a prep with pills, which seems easiest, but you don't recommend that option.
I think it's been pulled off the market in the United States.
Okay.
Yeah, I think it has too much nephrotoxicity. It hurts kidneys too much. People do not drink the amount of water they're supposed to do with that. So I think it is not available here in the US anymore. Are there any specific foods that one could eat to prevent colon cancer?
Well, we talked about the diet in general. I don't know if we have any specific data on any specific foods, but certainly limiting red meat, eating fruits and vegetables, avoiding, I guess the processed meats and stuff, not drinking, not smoking will all improve your chances of not developing polyps. But polyps are extremely common. If you look at a 25-year age group, which is what the current national societies do, 50 to 75, we find polyps in men. This is average risk, no family history, no personal history, no inflammatory bowel disease. In our practice, we find polyps in men, precancerous polyps, about 50% of the time, and women about 40-45% of the time. Now granted, we don't separate that into 50-55, 55-60, 60-65, so I think it's going to be higher in the older age group, but polyps are common.
What are all the various signs of blood in the stool?
Red blood, maroon blood, black stool, and then the stool kits that test for the different components of the blood. Now, some blood loss, like patients who present with an iron deficiency anemia, that's so slow and so long, they never see any overt blood. They just become anemic. And so their stools will be normal.
Are benign adenomas, yes, something to be concerned about?
Yes, so adenomas are the precancerous type polyps. They are benign because they don't have cancer in them, but they have a cancer potential. We remove them. We just take them out.
And then we make sure you don't grow more ones, and then we'll prevent you from developing cancer.
All right. Let's see. You talked about Cologuard before. Is it an acceptable alternative to a colonoscopy? So
Yes,
kind
it
of-
is. It's in part of all the guidelines from all the national organizations and the American Cancer Society and the U.S. Preventive Task Force. So it's in there. It is not, so as I said, any type of screening is better than nothing, right? If you do any type of screening, we can decrease colon cancer incidence and death 60, 80%. So the Cologuard has a role. It's just, it talks about, and they advertise it as early detection. And what I tell patients is I would like to prevent your cancer rather than detect it early. But yes, it has an absolute role, so do Hemoccult, so do FIT test. All of them do. So if you find colonoscopy or virtual colonoscopy or flexible colonoscopy just not for you, please do something.
What language would I use when writing to senators regarding changing insurance coverage?
I think that when you write to them, you say that the difference between surveillance and screening, right? So surveillance should be covered as screening because it's not evaluating an abnormal symptom or it's not evaluating diarrhea, anemia. It's just coming in at a timed interval for a colonoscopy. And I don't see any difference from it from screening except that you've had a polyp before. We just have to keep writing them. Now, if people don't remember, but when the ACA came into effect, mammograms were not included in the first draft. So the first year of the ACA, mammograms were not covered. And then they wrote it in, and then it was covered. So they can do that with surveillance and screening.
You didn't mention eating fiber. Is that also important?
Fiber is in the fruits and vegetables. The fiber is, I mean, it's more the fruits and vegetables with the antioxidants, but whole grains, absolutely, they're important too.
I assume that Medicare covers a colonoscopy at 75. It should be my last time. I have no family history.
Correct. If we don't find anything, we're going to tell you you don't need to do it again. For screening, you may have diarrhea or anemia that needs evaluation, but not for screening. Now, if we find very large polyps and your interval is 3 years or something, it may not be your last one. You may have another one after that.
I had a partial, we have time for this question and then I'll ask one more. Okay?
Yeah, I'm fine.
All righty, very good, very good. I had a partial colonectomy.
Yeah,
I had a partial colonectomy due to stage 4 cancer. Now I get regular CT scans. Should I also get a colonoscopy?
Yes. Yeah.
Excellent,
So
excellent.
what I would do is I would make sure that patient talks to their oncologist, but likely we usually look a year after the resection to make sure nothing has grown, and then in a couple years.
Perfect. All righty then. I'll ask one more question as I'm walking up to close our program. Would doctors recommend consuming no alcohol as opposed to moderate consumption were it not for the size of the huge alcohol industry?
So the current guidelines are decreasing alcohol intake. They will say if you're a social drinker and you have a drink or so a couple times a week, you are classified at a higher risk. So yeah, no alcohol is probably the best. It's not what I do, so it's hard for me to tell you not to drink anything when I have some drinks sometimes. But certainly no alcohol is better than a little alcohol, which is better than a lot of alcohol. So